Heart anatomy and physiology. Let's review. We'll start by taking a look at the anatomy of the human heart. Now, this picture might look a little bit funky, and that's really just because they made the vessels skinnier so that they're more clearly defined. You should practice labeling the heart using images from online, in your textbook, or in this interactive course. But you want to be able to get good at labeling all of the parts of the heart. We're going to do a quick review here, moving through the heart in the same way that blood flow does. So we'll start with blood that is entering into the heart. Deoxygenated blood from the body is returning to the heart from the inferior and the superior vena cava. Is going to empty into the right atrium and then go through the tricuspid valve into the right ventricle, and then through the pulmonary semilunar valve into the left and the right pulmonary arteries. That's going to take that deoxygenated blood to the lungs where we're going to have diffusion, get rid of CO2, we'll pick up oxygen and bring that oxygenated blood back to the heart through the pulmonary veins, again from the right and the left side. Both will enter into the left atrium, which will then go through the mitral valve or bicuspid valve into the left ventricle. There's one more valve here that you can't quite see, but that's going to be the aortic valve that goes into the aorta. And then you have the aortic notch. And then from there, you'll branch into arteries that will take you into the systemic vascular system. There are multiple layers of the heart. So we're going to start with the outside. The pericardium surrounds the heart, and it's made up of two different layers. We start with the fibrous pericardium. The fibrous pericardium is tough. It's a loose, inelastic sac made up of really dense connective tissue. What do you think the purpose of the fibrous pericardium is? It's going to protect and anchor the heart and prevent overfilling. Then we come to the serous pericardium. And again, there's two layers to this as well. The parietal layer lines the pericardium, and the visceral layer lines the surface of the heart and the great vessels. The heart wall is then made up of three layers. The outer part is the epicardium, which is also where the visceral pericardium is. The middle part is the myocardium. That's really the heart muscle. And then the endocardium is the inner layer of the heart. This is made up of a squamous epithelium with small blood vessels and a few bundles of smooth muscle. There's a small amount of fluid between the parietal and the visceral pericardium layers. This works a lot like the parietal and the visceral layers of the pleural space, where we have a little bit of fluid there that is going to help minimize friction. Here, rather than minimizing friction of the lungs expanding, we're minimizing friction as the heart beats. If there is a buildup of fluid, though, what is that called? Pericardial effusion is the buildup of fluid. What happens if there is a large pericardial effusion? That will cause a cardiac tamponade. This is a large pericardial effusion that can affect pumping function, decrease cardiac output, and eventually lead to shock and cardiac arrest. How about pericarditis? What is that? Pericarditis is inflammation of the pericardium. It can be caused by trauma, infection, a heart attack, and cancer. And it can lead to an effusion and cardiac tamponade. So the earlier that it can be caught and treated, the better off the patient typically is. Let's talk about the valves of the heart a little bit more. We'll start with the atrioventricular valves. These are the valves that are between the atria and the ventricles. So we have the tricuspid on the right side, and we have the mitral or the bicuspid on the left side. They'll be closed during ventricular contraction to prevent backflow into the atria. The other important anatomical part of the heart to note here are the chordae tendineae, which anchor the valves to the papillary muscle. If these tear, it will cause valvular insufficiency. During contraction, those papillary muscles pull the chordae and keep the valves from pushing back into the atria. During diastole, the valves will then open and allow for blood flow from the atria to the ventricles. Next up are the semilunar valves. These are the valves that separate the ventricles from their arterial outflow. So we have the right ventricle that then has the pulmonary valve. That blood flow will go through the pulmonary valve to the pulmonary artery. And then from the left ventricle, it will go through the aortic valve to the aorta. During systole, the valves open, blood is ejected into the arteries. During diastole, the valves close. And again, this is to prevent backflow. Regurgitation. What is regurgitation? Regurgitation occurs when the valves are damaged or incompetent, and that allows backflow. How about stenosis? Stenosis is the narrowing or the constriction of the valve that increases pressure in the proximal chambers and vessels. I'm also going to talk a little bit about coronary circulation. That's because the heart has a high metabolic rate and requires a significant amount of oxygen supply. This is done through the coronary system. So the left and the right coronary arteries are coming directly off the aortic root, and they are what is supplying oxygen to the heart tissue. So you can see, and there's multiple branches that come off of the left and the right artery. It's really important to note that coronary artery blood flow occurs during diastole. During systole, it increases coronary pressure and it prevents blood flow. That is why diastolic pressure is so important. If diastolic pressure is very high, it can reduce coronary blood flow. So then we have coronary veins that are going to take blood back to the heart after it goes through the myocardial capillary bed. And you'll notice that the veins really very closely parallel the arteries. So we have arteries that are taking oxygenated blood to the heart tissue. The heart tissue is utilizing that oxygen and then draining back into the veins to take that deoxygenated blood back to the heart. And so these all come together and empty into the coronary sinus, which empties primarily into the right atria. But we do have these Thebesian veins that actually drain into the right and the left atria, and this creates an anatomic shunt because we have deoxygenated blood that is going into the left side of the heart. What is normal anatomic shunt? It is about 2 to 3% of total cardiac output. The last thing we'll talk about is the heart muscle itself. The heart's ability to pump depends on being able to initiate and conduct electrical impulses and then have synchronous myocardial contraction. So, myocardial tissue has to have certain properties or characteristics to it, and that includes excitability, the ability to respond to stimuli, an inherent rhythmicity or spontaneous rhythmicity that allows it to initiate a spontaneous electrical impulse. Conductivity is the ability to spread the electrical impulses. And then contractility. So it's going to contract in response to that electrical stimulation. And one other important vocabulary piece here is the refractory period. This is the time in which the myocardium cannot be stimulated. And all of this is really going to play into EKGs as we start to talk about that. Let's review our key points. You want to practice labeling heart anatomy. You also want to practice drawing blood flow, and I'm going to show you how to do that in another video. Remember that the heart is surrounded by the pericardium, and there is fluid between the visceral and the parietal pericardium to prevent friction as the heart beats. The heart has 3 layers: the epicardium, myocardium, and endocardium. The myocardium is the heart muscle. Valves in the heart prevent backflow as blood moves from the atria to the ventricles and from the ventricles to the arterial outflow vessels. The heart receives blood flow through the coronary arteries during diastole. Most of the coronary blood returns to the right side of the heart, but a small amount returns to the left side, which creates a normal anatomic shunt. Heart muscle has excitability, inherent or spontaneous rhythmicity, conductivity, and contractility. The interactive version of this video, along with other interactive practice, can be found in the ECG and hemodynamic study course on www.myvresp.com.